Dr. Saeed, and good evening. We'll talk about white coat and mask hypertension. I will start with the case. This is a 57 years old account executive patient present for a blood pressure follow-up visit. Elevated blood pressure identified 2 months back during annual examinations. In terms of blood pressure taken at local pharmacies have all been normal. He had normal hematology, biochemistry, renal function, and electrolytes, normal EKG with no evidence of LVH, office blood pressure using the auscultatory wall-mounted mercury shows his blood pressure 152 over 102. So how would you explain these observations? Discrepancies between the office blood pressure or the out-office blood pressure can reveal two things. Either mask hypertension, which the office blood pressure will be normal, and the out-office blood pressure will be high. Or the office blood pressure will be high, but the out-of blood pressure will be normal, so this is a white coat hypertension. So I will review the recommendation of the ACC-AHA guideline in the detection and management of white coat and mask hypertensions. The first recommendation, in adults with untreated systolic blood pressure that's more than 130 but less than 160, and diastolic blood pressure more than 80 but less than 100, it is reasonable to screen for the presence of white coat hypertension using either ambulatory blood pressure monitoring or home blood pressure monitoring before diagnosis of hypertension. So the white coat hypertension, the prevalence about 13 to 35% in some population with the disease. The ambulatory blood pressure monitoring and the home blood pressure monitoring are better predictor of hypertension-related cardiovascular risk than office blood pressure measurements. Ambulatory blood pressure monitoring is the preferred one. Major clinical relevance of white coat hypertension typically associated with minimal to only slightly increase the risk of cardiovascular disease and all-cause mortality risk. In the absence of ambulatory blood pressure monitoring resources, home blood pressure monitoring provides reasonable but less desirable alternative to screen for white coat hypertension. But overall, the home blood pressure monitor with ambulatory blood pressure monitoring is only 60 to 70% for detection of white coat hypertension. For recommendation 2, in adult with white coat hypertension, periodic monitoring with either ambulatory blood pressure or home blood pressure monitoring is reasonable to detect transition to sustained hypertension. The incidence of white coat hypertension converting to sustained hypertension which justify addition of antihypertensive treatment to lifestyle modification is 1 to 5% per year by ambulatory blood pressure or home blood pressure monitoring, with a higher incidence of conversion in those population whose already their blood pressure elevated in the elderly, obese patient, and black races. In adults being treated for hypertension with office blood pressure reading not reaching the goal and home blood pressure monitoring reading suggestive of a significant white coat effect, confirmation by ambulatory blood pressure can be useful. Overlap between the home blood pressure monitoring and both daytime and 24 hours ambulatory blood pressure monitoring in diagnosing white coat hypertension is only 60 to 70%. Data for prediction of cardiovascular risk are stronger with ambulatory blood pressure monitoring than with the office blood pressure. Because of the diagnosis of white coat hypertension may result in a decision not to treat or intensifying the treatment in patients with elevated office blood pressure, confirmation of the blood pressure control by ambulatory blood pressure in addition to the home monitoring provides added support for the decision. In adults with untreated office blood pressure, constantly between 120 to 129 millimeters mercury and of the systolic blood pressure, or between 75 to 79 of the systolic blood pressure, screening for mask hypertension with home blood pressure monitoring or ambulatory blood pressure is reasonable. In contrast to white coat hypertension, mask hypertension is associated with increased risk of cardiovascular mortality, double than the white coat hypertension. And therefore, out-of-office reading are reasonable to confirm the blood pressure control seen with office reading. For the recommendation 5, in adults on multiple drug therapies for hypertension and their office blood pressure within 10 millimeter mercury above the goal, it may be reasonable to screen for white coat effect with home blood pressure monitoring or ambulatory blood pressure monitoring. White coat effect has been implicated in office measured and controlled hypertension and pseudo-resistant hypertension. Blood pressure control may be underestimated when subsequently assessed by ambulatory blood pressure. The risk for vascular complication in patients with office measurement and controlled hypertension with the white coat effect is similar to the risk in those with uncontrolled or with controlled hypertension. White coat hypertension and white coat effect raise concern that unnecessary drug therapy for hypertension may be intensified or initiated. Because of diagnosis of white coat hypertension and white coat effect would result in a decision to not to treat elevated office blood pressure reading, confirmation of a blood pressure control with ambulatory blood pressure monitoring or home blood pressure monitoring provide more definitive support for the decision not to initiate antihypertensive drug therapy or accelerate the treatment. It may be reasonable to screen for mask and control hypertension with home blood pressure monitoring in adults being treated for hypertension and office reading at goal in the presence of a target organ damage or increase overall the cardiovascular risk. Like mask hypertension in any treated patient, mask and control hypertension is defined in a treated patient with hypertension by office reading suggesting adequate blood pressure control, but out of office reading that remain constantly above the goal. The cardiovascular risk profile for mask and control hypertension appear to follow the risk profile for mask hypertension. Although the evidence is constant in identifying the increased risk of mask and control hypertension, evidence is lacking on whether the treatment of mask hypertension or mask and control hypertension reduce the clinical outcomes. And the last recommendation, in adults being treated for hypertension with elevated home blood pressure monitoring readings suggestive of mask and control hypertension, confirmation of the diagnosis by ambulatory blood pressure monitoring might be reasonable before intensifying the antihypertensive medications. Although both the ambulatory blood pressure and home blood pressure are better predictors of cardiovascular risk than office blood pressure reading, ambulatory blood pressure confirmation of elevated blood pressure by home blood pressure monitoring may be reasonable because of the more extensive documentation of cardiovascular risk with ambulatory blood pressures. However, unlike the documentation of a significant white coat effect to justify the decision not to treat an elevated clinic blood pressure, it is not mandatory to confirm mask and control hypertension determined by home blood pressure monitoring.